Good afternoon, everyone. This is Kim Beer. I'm the Director of Public Policy at the Christopher and Dana Reeve Foundation. And thank you so much for joining us. We're going to get started in just about 1 minute. Great. Good afternoon. Thank you again so much for everyone who's decided to spend some time with us this afternoon. I am Kim Beer, the Director of Public Policy at the Reeve Foundation. We are thrilled to welcome our special guest keynote expert speaker, Andrés Gallegos from Chicago, who will present. We have planned a three-part series of webinars addressing accessible healthcare for persons with paralysis and mobility disabilities. And we've been very honored to partner with Andrés on this project, and part one will address barriers and legal rights. And before we get started, I would like to just introduce our keynote speaker. Andrés is a shareholder with the law firm of Robbins, Solomon, and Patt in Chicago, Illinois, where he focuses his practice and he leads the practice on disability rights in healthcare. He founded and directed the law firm's disability rights practice, which has an emphasis on improving access to healthcare and wellness programs for persons across all types of disabilities. He has written numerous articles for national and state professional healthcare and legal organizations on matters relating to the application of the ADA, the Rehabilitation Act of 1973, and Section 1557 of the Affordable Care Act. In February of 2018, Andrés received a congressional appointment to the National Council on Disability, which is a 9-member council that advises the President, Congress, and federal agencies on policy issues affecting persons with disabilities in the country. He's also a recent 2-term past member of the statewide Independent Living Council of Illinois, having been appointed by the governor, and a past chairman of the board of directors of Access Living of Metropolitan Chicago, Chicago Center for Independent Living. He's a graduate. He graduated with honors from the University of Southern Mississippi with a Bachelor of Science in Business Administration, and he also attained a Juris Doctorate from the St. Louis University School of Law. He is a veteran of the United States Air Force, having served honorably for 14 years. We welcome Andrés, and thank you so much for joining us as well.
Kim, thank you so much. And thank you to the Reeve Foundation for hosting this webinar. It's great to be with you to discuss this critically important topic. As Kim mentioned, this is only part one of a trilogy of webinars focusing on accessible healthcare for persons with paralysis and mobility disabilities. Today, we start by discussing barriers and legal rights. In part two, scheduled for August 20, we focus on the pandemic and its effect on persons with disabilities and explore advocacy strategies. And in part three, scheduled in September, led by the Reeve Foundation, we will address how the Reeve Foundation will elevate accessible healthcare for persons with disabilities as a long-term advocacy priority, and will identify specific ways the community can share their stories and be involved in working towards solutions. The specific date of that webinar is to be determined, and once it is, we will pass it along. Before I continue, I have to clarify that although I am a member of the National Council on Disability and an attorney with Robbins, Solomon, and Patt Limited, the expressions of opinions or views during this webinar are strictly mine and not those of the council or my law firm, and neither are they the opinions of our gracious host, the Reeve Foundation. Also, I have to disclaim that nothing that I discuss here should be construed as being legal advice regarding any specific matter affecting any of the participants in this webinar. With that behind us, why are we here? Obtaining and maintaining good health is important to all people. However, it's critically important for persons with disabilities. It's the predicate to our ability to live, our ability to learn, and our ability to earn. However, accessible healthcare has been elusive, and you see that reflected in these headlines from across the country. First in Boston last February. In New York in August 2018. And in Iowa on April 2018. While these headlines pertain to Boston, New York, and Iowa, similar and identical issues do take place all throughout the country. So what are we going to be talking about? We first want to focus on barriers to healthcare so we have a common understanding of the things that impede us from getting the appropriate care that we need. We'll then focus on healthcare providers' legal obligations and our legal rights under federal non-discrimination law. It's important we understand what those are. Each of us individually have the power to address those barriers. What's more, I submit that each of us have an obligation to address those issues, not just for ourselves, but for others that come behind us. Moreover, understanding what healthcare providers' legal obligations are and what our legal rights are is the predicate for you to become a more effective advocate. We'll then explore what the legal obligations are of managed care organizations, and throughout we'll discuss the results of the surveys that many of you completed when you registered for this webinar. Then finally, we reserve time for your questions, and I hope that you'll have many. Let's go. When I sustained my spinal cord injury in a car accident nearly 24 years ago this November, I thought that my doctor's office and hospitals would be places of refuge, places that understood my disability and were welcoming to me. Yes, not only was I naive, I was wrong, because what I found is this. If I didn't bring someone with me, I struggled to get inside of medical buildings. If I didn't bring someone with me, there was no one willing to assist me to fill out forms and get my insurance card out of my wallet. If I didn't bring someone with me, in the dead of Chicago's winters, there was no one to help me take off my coat or put it back on. If there wasn't someone with me, I had to remain in my wheelchair while getting a complete physical examination. And if I didn't bring someone with me, the percentages were high that what I had to say about how I felt wouldn't be heard or would be dismissed. There are many barriers to accessible health care, and time doesn't permit us to talk about all of them here. But I do want to touch on some. The first is transportation. Transportation can be a significant barrier if you have no reliable means to get back and forth to a doctor's office. It makes it difficult to maintain good health. But what tends to happen is that if it's too bothersome, too expensive, or too difficult, we just don't go to the doctor's office unless we absolutely have to. Programmatic barriers. This means the totality of a healthcare provider's policies and practices that are part of its delivery of healthcare services. The totality of things that hinder our ability to receive the same quality of care as others. This includes, among other things, providers' knowledge and understanding of people with disabilities. Then there's the big three: attitudes, policies, and physical barriers. Let's explore them a bit deeper, beginning with attitudinal barriers. We need to recognize that we have an ugly history with our healthcare system going back to the turn of the century. We need to figure out where we've been to understand where we are now. In the late 1800s to early 1900s, eugenics laws spread like wildfire. Eugenics is the misguided belief that controlling genetics could improve the human race. It's the practice of controlled selective breeding of human populations, and in many instances, that was done through forced sterilization. Indiana was the first state to have such a law, and then 32 other states. It permitted the forced sterilization of confirmed imbeciles, idiots, and rapists in state institutions. In addition, throughout the country, doctors practiced forced sterilizations on persons they deemed unfit, including persons with physical disabilities, removing their ability to have children. It's estimated that over 70,000 people deemed to be unfit for society were sterilized against their will. In addition, they were also forced to enter institutions and asylums. Many spent their entire lives there. The purification and segregation of persons with disabilities was considered merciful actions. It ultimately served to keep us invisible and hidden from a fearful and biased society. While eugenics ended here in 1963, remnants still exist today. A countless number of doctors refuse to provide women with disabilities reproduction counseling or birth control, believing either that persons with disabilities don't have sex or shouldn't reproduce. We need to talk about our ugly history with society. Historically, we were considered meager, tragic, pitiful, unfit, unable to contribute to society, except we served as ridiculed objects of entertainment in circuses and in exhibitions. We were assumed to be abnormal and feeble-minded. In the mid-1800s, there existed in many U.S. cities the ugly laws. Those laws were in place for just over 100 years, from the 1860s until the 1970s. They sanctioned state-sponsored discrimination of persons with disabilities. The first appearance of these laws was in 1867 in San Francisco. The laws, in essence, stated, if you are visibly disabled, get off the streets. Stay out of the public view. Chicago's law was the most infamous, passed in 1911. The law stipulated, as you see here, it made it illegal for us to be on the streets. When adjusted for inflation today, the monetary fine would be between $23 and $1,200. These laws shaped how the public viewed disability and, conversely, how persons with disabilities viewed themselves. These ugly laws were not repealed until the 1970s. Chicago's was the last to repeal its ugly law in 1974. I used to think that it didn't matter what people thought about us, that it mattered more what we as persons with disabilities thought of ourselves. Again, I was wrong. It matters, particularly when those people are medical professionals. How they see us is the way they treat us. As reported in the Annals of Emergency Medicine in 1994, a survey was conducted of 153 emergency room providers. The question to the doctors was direct. Would you want to be alive if you sustained a high-level spinal cord injury? Only 18% said yes. A similar question was asked to 128 persons with high spinal cord injuries. Are you glad to be alive? 92% said yes. Why is there such a huge gap between their perception and our reality? Does it make a difference? It absolutely does. These opinions can impact the decisions physicians make in treating persons with paralysis, mobility, and other disabilities. It also impacts what they tell our families about critical care decisions and options. So that was in 1994, over 20 years ago. Have things changed? Very little has changed. As a prelude to the release of our most current research on healthcare disparities, just published last month, Dr. Lisa Iazzoni, a professor of medicine at Harvard Medical School, who is one of the foremost authorities on the importance of accessible healthcare for persons with disabilities, is clearly letting us know that there remains a significant gap between their perception and our reality. And in case anyone is questioning whether it's really important that we concern ourselves with the attitudes of physicians towards people with disabilities, All we have to do is look back to last month on June 11. We learned horrifically of the deadly consequences of ableism with the death of Michael Hickson at St. David's South Austin Medical Center in Texas. One of Mr. Hickson's doctors was recorded telling his wife that he would not treat him for COVID-19 as he had a low quality of life. He could not walk and he could not talk. And no intervention would make him walk and talk. To be clear, Mr. Hickson was not seeking a cure for his quadriplegia. He wanted to be cured of the virus. It's my opinion that there's an insidious plague affecting the medical community. Disability has traditionally been viewed within the general medical community as a medical condition or an illness which amounts to a deviation from biological norms, from social norms resulting in dependency. The origin of this lies in the medical model of disability, a conceptual framework for the understanding of disability which can provide some insight into why these attitudes exist and how they are reinforced in society. The medical model sees disability as a medical problem, a defect lying within the individual. This model is the root of the most negative attitudes towards people with disabilities. Those subscribing to this model see us as defective and dependent. With the rise of the medical profession in the 19th and 20th century, the medical model began to dominate the view of disability. In this model, the problems associated with disabilities are seen lying solely within us in our medical condition or impairment. The desired solution to these problems is often the cure or rehabilitation in order to fix the defect so that we can become closer to normal. It's only when providers believe that individuals with paralysis and mobility disabilities can and should have full productive lives that they will make facilitating that goal part of their treatment. Research indicates that patients' relationships with their healthcare providers influence their health behavior. Historically, provider-patient relationships were paternalistic, with healthcare providers making decisions but not necessarily including or valuing the perspective or goals of their patients. Attitudes are significant barriers to accessible healthcare, and those attitudes influence a provider's policies, practices, and procedures. Policy barriers. Examples of policy barriers you see here. A chief complaint from all patients, abled and disabled, is that physicians don't spend sufficient time with us during a visit. Now that's true for everyone, but more for us, because the time available to spend with us is shortened as we struggle to get ready for the examination once inside the exam room. Not purchasing accessible medical equipment and furniture. This is a conscious decision. The equipment exists. Its costs are not offensively higher as non-accessible equipment. I want to mention a practice barrier that really detrimentally affects persons with mobility disabilities, and that's doctors chronically being late. If you have an appointment scheduled at 1 p.m., the doctor doesn't see you until 1:30 or 1:45 p.m. if we're lucky. What physicians don't understand that if someone is dependent upon public transportation, and in particular paratransit, they need to be seen on time so they don't miss their ride going back home. Paratransit will only wait 5 to 10 minutes after the scheduled pickup time, and then they're gone. And if you're not out there on time to catch your ride, you're stranded. And finally, physical barriers. What's wrong with this picture? Changing rooms that are too small. It's inconceivable that a wheelchair will be able to get into that dressing room. Small, cluttered examination rooms with too much furniture. If we can't get in, how do we get a complete examination? Looking at this picture, what's the likelihood that lift equipment will be in there, will fit in there with our wheelchair? Here's what concerns me the most. The unwillingness to weigh us, or the inability to weigh us because of the absence of an accessible wheelchair weight scale, puts our health in danger. For a diabetic, the change in weight of as little as 4 pounds plus or minus can have a detrimental effect on the management of their diabetes. In addition, accurate weight and height measurement is often required to calculate the correct dosage of many medications, particularly those for children. Speaking of children, mothers of children with mobility disabilities have told me that they often have to lift their child from their wheelchair and cradle them in their arms while trying to balance on a weight scale, as you see here. That's the only way to get their child weighed. And after they're both weighed, the mom gets weighed separately, and then they do the math. Accurate weight management is also critical to determining the amount of anesthesia to provide us before surgery. Fortunately, many hospital beds have integrated weight scales. Yet the overwhelming number of us who utilize mobility disabilities do not get weighed. Healthcare providers ask us for their weight, they guess at our weight, they use a previously recorded weight, or they don't even bother. Kim, looking at the surveys that we asked, what question did we ask with respect to getting weighed?
I am finding it right now. So the question was, that many of you answered, how is your weight captured at your primary care provider's appointments? Would you like me to read all the choices?
What were the choices?
The first choice was a wheelchair accessible weight scale. That was A. B was they use a previously recorded weight. C, either they guess or they ask me for my weight. C, they usually do not ask me to weigh or for my weight. And E, I use the standard office scale.
So there were 12 survey respondents. 8 out of the 12 respondents stated that they either asked for their weight or their providers guessed at their weight. Now, guessing is an acceptable method, a recognized method of determining someone's weight, but it requires 2 healthcare professionals to do separate guessing, and then they average that out. That's not what takes place when they're guessing at their weight. They're either asking us, or a nurse or a doctor simply looks at us and by magic determining what our weight is. Never is it accurate. Overwhelmingly, dental examinations are provided to us while we remain in our wheelchairs. If you don't have a wheelchair that tilts and reclines, and the majority of us do not, it can be incredibly painful, incredibly uncomfortable. For dental exams, Kim, what did we ask here?
We asked for dental examinations. I am examined A, while I remain in my wheelchair, which tilts and or reclines. B, while I remain in my wheelchair, which does not tilt and or recline. C, on an examination chair after being transferred by the dentist staff. D, on an examination chair after I transfer myself. Or E, on an examination chair after being transferred by someone who accompanies me to the appointment.
So 9 of the 12 respondents answered this question. 3 of the 9 remained in their wheelchairs, but their chairs tilt and recline. 6 of the 9 were able to transfer themselves or get treated while in the examination chair, and a couple had to bring someone to assist them in transferring. The same is true for examination tables. The absence of height-adjustable examination tables and correspondingly the absence of lift or transfer equipment means that we're going to receive a less thorough examination than our non-disabled counterparts. Do we need to be transferred out of our wheelchairs onto an examination table for every visit to our doctor's office? It depends why we're there. If we're there because we're complaining of our throats or ears hurting, then no. We can receive a thorough examination while remaining in our wheelchairs. But to receive a complete physical examination, absolutely yes. to receive a thorough physical examination, to receive a thorough gynecological examination, to examine our body thoroughly for pressure sores. We need to be transferred, and we're not. When clinically appropriate, we should be transferred. In the survey for this webinar, we asked the questions about transferring here. Kim, what did we ask?
When I need to transfer from my wheelchair onto an examination table, A, my PCP office staff uses a lift equipment to transfer me. B, my PCP office staff physically lifts me. C, I transfer myself. D, I'm required to bring someone to transfer me. Or E, I'm never transferred. I remain in my wheelchair.
In 24 years, I have been never transferred out of my chair onto an exam table for a complete physical examination. And in one instance, my longtime primary care provider was on vacation when I had my physical scheduled. His partner came in, took a look at me. I had my shirt off, and he was able to do a pretty sound examination of my upper body. But when it pertained to my lower body, he looked at me and said, I assume everything below the waist is fine. How the hell does that happen? 5 out of 9 respondents to our survey question answered that they also remain in their wheelchairs for complete physical examinations. 2 of the 9 answered that they've never had a complete physical examination. With respect to accessible exam tables, Kim, what did we ask here?
Around, let's see, the one where at my last complete physical examination, or
on whether or not the
height?
PCP had an exam table.
We asked, my PCP's office had a height adjustable examination table. Yes, no, or I'm not sure.
10 of the 12 respondents answered this question. 5 of the 10 said no, their PCP did not have an accessible examination table, and 2 other answered that they were not sure. The remaining 3 answered yes, their PCP primary care provider has an accessible examination table. We also asked about transferring onto the examination table. Kim, what did we ask here?
When I need to transfer from my wheelchair onto an examination table, A, my PCP's office staff uses lift equipment to transfer me. B, my PCP's office staff physically lifts me. I transfer myself. I am required to bring someone, or I'm never transferred. I stay in my chair.
So 8 of the 12 answered this question. 2 answered that they're never transferred. 2 answered they're required to bring someone with them. And 4 of the 8 were able to transfer themselves. So how pervasive is the problem of not being transferred from your wheelchair onto an examination table? As reported in the Annals of Internal Medicine in 2013, 256 specialist practices were surveyed in Atlanta, Dallas, Houston, Portland, and Boston. And here are the results. 91% had no height adjustable examination table and no lift equipment. 22% couldn't accommodate us if we couldn't transfer on our own. And 18% simply would not transfer or could not transfer patients. Our law firm conducted a similar survey in 2016. We looked at Illini Care, which is Centene Corporation's managed care subsidiary in Illinois. We surveyed 25 primary care groups that were identified in Illini Care's network directory as being accessible. And here are the results. 80% of them could not transfer patients. 76% couldn't weigh us. 68% couldn't accommodate us if we weren't able to independently transfer. And 64% did not have height adjustable examination tables. What's the significance of all this? It leads to significant health disparities. As you see here, when comparing people with disabilities in general to their non-disabled counterparts. We're delayed significantly in getting the health care that we need. We tend to not engage in fitness activities as consistently as we should, and we use tobacco far greater than persons who are not disabled. And then we tend to be overweight or obese, have high blood pressure, and experience symptoms of psychological distress. In addition, we typically do not have annual dental examination visits. If it's going to be painful because we don't have a chair that tilts or reclines, we tend to avoid doing that. And we tend to avoid going to places where we're not welcome. We tend to experience greater difficulties in getting the health care that we needed. For women with disabilities, they don't have mammograms in the past 2 years, and chances are they would not have a Patt test within the past 3 years. When we focus on health disparities affecting persons with paralysis and mobility disabilities, we're more likely not to have a complete and thorough annual physical exam, as we just discussed, not actively be weighed for years, as we just discussed, and we tend to be examined while remaining in our wheelchairs, even though it's clinically inappropriate to do so. What concerns me, which we're going to talk about in a little bit, is denial to admission for mental health treatment for inpatients. We tend not to have or ever receive diagnostic tests or exams for breast cancer screening. We tend not to have or receive bone density screening and not receive colorectal cancer screenings timely. These all are critically important preventive diagnostic screening tests. We're not receiving them for the absence of accessible medical diagnostic equipment. In large part through no fault of our own, persons with disabilities use the healthcare system for disease management instead of its intended purpose, disease prevention. Now, I know what you may be thinking. Didn't the U.S. Access Board create standards for accessible diagnostic medical equipment? Well, they did, but today, as we speak, there are no enforceable standards for accessible medical diagnostic equipment. When the U.S. Access Board established these standards as required by the Affordable Care Act in January 2017, until they were adopted or are adopted by the Department of Justice, they are merely voluntary standards. The Department of Justice was scheduled to adopt these standards as mandatory obligations under the ADA, but on December 26, 2017, unexpectedly, they stopped the regulatory process and withdrew these regulations. Ostensibly, they have additional time to study their necessity. However, the Department of Justice has not taken any meaningful steps to assess the necessity of these regulations since December 2017. The fact that we still struggle to get into medical facilities, the fact that we're not receiving complete physical examinations, the fact that many healthcare providers lack the ability to transfer or to weigh us, the fact that we're less healthy than our non-disabled counterparts, and that we're at far greater risk for life-threatening diseases and conditions than those who are not disabled, many of which are easily preventable or can be detected and managed early. All of this is happening despite the long existence of federal non-discrimination mandates. Healthcare providers have federal mandated obligations to not discriminate against us in the provision of healthcare services. We have rights under those same laws. Rights to ensure that we have an equal opportunity to participate in healthcare providers, facilities, and services in the same manner as persons who are not disabled. That has been the law of this land for 47 years. What are those federal laws? As you may know, as you see here, Section 504 of the Rehabilitation Act, the Americans with Disabilities Act, and Section 1557 of the Affordable Care Act. As you may know, last month, Health and Human Services, Office of Civil Rights, gutted the protections under Section 1557 of the Affordable Care Act, which we'll discuss. Section 1557 is still in existence, but diluted significantly. There's one state law that I want to talk about as well that's critically important, and that is safe patient handling laws. As I mentioned, for 47 years this September, Section 504 of the Rehabilitation Act of 1973 has been in effect. If you saw the movie Crip Camp, which I hope you have, and if you haven't, you need to, you know that the regulations came about after the Section 504 sit-in, which lasted for 25 days and remains the longest nonviolent occupation of a federal building in United States history. The regulations apply to any recipient of federal financial assistance. For example, those providers that accept Medicare and Medicaid. It states that no otherwise qualified individual with a disability in the United States shall solely by reason of his or her disability be excluded from the participation in or be denied the benefits of or be subjected to discrimination under any program or activity receiving federal financial assistance. The specific regulations are sparse as it relates to healthcare, but it requires healthcare providers to designate someone to serve as a coordinator to ensure the provider complies with these non-discrimination requirements. It also requires the adoption of grievance procedures so complaints of disability-based discrimination can be fairly dealt with. The Department of Health and Human Services Office of Civil Rights as primary jurisdiction for the enforcement of these regulations. Additional requirements under Section 504. These are overarching obligations. When a doctor's office tells you they cannot treat you in its facility because they are not wheelchair accessible, that's an example of the denial of an equal opportunity to receive their benefits or services. When you get your eyes examined and you're not transferred onto the examination chair, or the examination chair does not swing away for you to position yourself with your mobility device in its place, and as a result you receive a manual eye exam instead of a digital eye examination, there's likely a strong argument that the optometrist's benefits or services being provided to you are not as effective as those provided to you to a non-disabled counterpart. And that, ladies and gentlemen, is discriminatory. When lift and transfer equipment is not available, when wheelchair accessible weight scales are not available, the services are being provided in a manner that limits or has the effect of limiting our participation, and that is also discrimination. As I mentioned, the 504 regulations are sparse in details and specificity as it relates to healthcare providers. More was needed, and disability rights activists fought for the passage of the Americans with Disabilities Act, enacted 30 years ago next week on July 26. Among other things, it established regulations that are significantly more detailed than the regulations under Section 504 as it pertains to healthcare providers. While the Americans with Disabilities Act applies to public entities in the healthcare context, that means any hospital or healthcare system, clinic, or other healthcare facilities that are owned and operated by a state, county, or city, my focus is mainly going to be to addressing the ADA as it applies to healthcare facilities and systems that are defined as public accommodations. That is, owned by private entities that is open to the public. The ADA does not apply to healthcare providers that are owned and operated by religious entities, which is a significant exception. In 2019, U.S. Catholic Healthcare was the nation's largest group of not-for-profit healthcare providers. According to the Catholic Health Association of the United States last year, 1 out of every 7 patients in the United States was cared for in a Catholic healthcare facility, and yet they're exempt from the ADA. Under Title III of the ADA, healthcare providers, as public accommodations, have general and overarching obligations to provide an equal opportunity for us to benefit and participate in their programs, facilities, and services. This means providing us with barrier-free health care with the specific obligations that you see here. Eligibility criteria. One of the issues that we're addressing that has just been recently brought to our attention is that the overwhelming number of inpatient mental and behavioral health facilities, at least in the Chicago area, but I suspect it's more widespread, will not accept patients who use wheelchairs or need assistance with some activities of daily living. You may be otherwise qualified, and that is suffering from severe depression that perhaps is manifesting into suicidal ideations. But if you can't walk, you're ineligible to be admitted as an inpatient to these facilities. That's a discriminatorily eligibility criteria being utilized. And it's sad to see that happen. In the instances that I'm referring to, there are two young ladies with cerebral palsy that are depressed because of the cerebral palsy and their use of the wheelchair. And they were denied admission to 8 separate facilities separately. So there's 16 behavioral health facilities in the Chicagoland area that are denying care simply because they use a wheelchair. And what's tragically ironic about this is that adding to the depression and their attempted suicide was the fact that they used a wheelchair. In 2010, the Affordable Care Act was passed, adding in the provisions of Section 1557 another federal non-discrimination mandate applicable to healthcare providers, and for the first time, healthcare insurance companies. The law prohibits discrimination on the basis of disability, among other categories, in certain healthcare programs and activities. While the act was passed in 2010, its regulations weren't finalized until 2016. It was applicable to any recipient of federal financial assistance from the Department of Health and Human Services. And much to my delight and the delight of other disability rights attorneys, there were no exemptions. Unlike the ADA, it applied to religious entities. But as you may know, on June 12, 2020, the Department of Health and Human Services obliterated the scope of the regulations. Where it was originally applicable to an entire healthcare system, for example, even if only one small aspect of it participated in Medicare or Medicaid, which is a form of federal financial assistance, now the rule only applies to that aspect of the healthcare system that receives reimbursement from Medicare and Medicaid. And religious entities, once again, are exempt from the rule's remaining requirements. The regulations still say that we're not to be discriminated against or denied benefits. And it used to extend those protections to persons who identify as LGBTQ+, but no longer. The requirements that you see here have also been removed in the new regulations. The rationale is that these are mainly redundant, and to a degree, HHS has a point. But the ADA never required public accommodations, that is, hospitals that are privately owned, to have an ADA coordinator. That only applied to public entities. Now, the obligations of Section 504, the ADA, and Section 1557 are not absolute. They are subject to defenses. That is, a hospital does not need to modify its policies, practice, and procedures if it results in a fundamental alteration to the nature of its services, activities, etc. Going back to the example I mentioned earlier about mental and behavioral health care facilities, an argument could be made that they don't have to modify their policies, practices, and procedures to accept patients with spinal cord injuries who, in addition to any mental or behavioral conditions they may have, also require intensive physical therapy and occupational therapy. As providing those services, PT and OT, are as part of their mental and behavioral health services would fundamentally alter their services. The law does not require healthcare providers to transform into something they are not. In addition, healthcare providers' obligations with respect to barrier removal is to remove only those that are readily achievable, that is, that are not too difficult or too expensive. By the way, the absence of accessible medical and diagnostic equipment is considered an architectural barrier by the Department of Justice. When assessing whether a barrier is too expensive to remove, it's not an assessment of that expense compared to the reimbursement the doctor may receive for a particular procedure. Rather, it's an assessment of the overall financial condition of the provider and the owners of his or her practice. Thus, an individual doctor should not be able to get away with not purchasing lift equipment or wheelchair accessible weight scales if Medicaid only reimburses him $100 to provide the individual with a physical examination, which is significantly less than the cost of that equipment. Now, assuming a healthcare provider can legitimately assert an undue burden defense, they are not necessarily relieved of their obligation to remove the barrier. They may take other readily achievable measures to remove the barrier. For example, if it's legitimately too expensive for a doctor to purchase a Hoyer lift, then a readily achievable alternative may be to train its staff on safe patient lifting techniques to facilitate a transfer of a patient from his or her wheelchair onto an examination table. It's important to know that you have, under Section 504, Title II and Title III of the ADA, at least until August 18, 2020, a private right of action. That is, you may file a lawsuit against a healthcare provider who discriminates against you on the basis of disability under either of those laws. And as you see here, you're entitled to compensatory damages, meaning the payment of money for the loss or deprivation of your civil rights or mental anguish, pain, humiliation, or anxiety caused by their discrimination. And you can compel them to fix things, as you're entitled to injunctive relief, meaning the right to compel them to do something or stop doing something. For example, as part of your claim, you can seek to have them make their facilities accessible as required under the ADA, or to purchase accessible medical equipment and furniture. Now, it's important to understand that you only have the right to have them fix things if you have an actual and definitive intent on returning to the office, clinic, hospital, or facility that you're complaining of. As I mentioned when we started this section, our rights to non-discrimination and to accessible health care are derived from those very same laws. So let's look at our rights under those laws. Our legal rights. We have the right to attend by ourselves. If we attend by ourselves, we have the right to expect and ask for assistance in getting prepared for the examination. We also have the right to be accompanied and bring someone with us to assist us as well. We have the right to request and receive assistance in checking in completing forms, in retrieving identification cards or insurance cards, or any other reasonable assistance. We have the right to request additional time for examinations and for treatments. With respect to additional time, a reasonable modification to a doctor's policies, practices, and procedures is perhaps to schedule our examinations at the end of the day so that we do have additional time to spend with the doctor, and so we have additional time to get set up for the examination. And we have the right to be placed in an accessible examination room when an examination is to occur. Many clinics, many facilities do have accessible examination rooms, only when we're scheduled to receive it, somebody else who's not disabled is using it. We have a right to insist to be examined or treated in an accessible examination room and to request one at the time that we make an appointment. Similarly, if we're going to be an inpatient in a hospital, we have a right to be placed in a patient room that's accessible, that we can move around in, that has an accessible restroom that we can get into and utilize. More examples of our patient rights. Assistance in getting dressed, undressed, and changing into gowns. Of getting weighed through the use of an accessible weight scale. To be examined or treated when clinically appropriate on an accessible examination table, on an accessible examination chair. We have the right to request transfer assistance, whether that's to simply spot us if we're capable of individually transferring, to provide us with a transfer board to facilitate a transfer from someone who's able to transfer independently, or to use lift equipment if we prefer lift equipment, or to manually and physically lift us if in fact that's all that we need or desire. And more importantly, it is our absolute right to say no to everything. We may advocate and insist that they have a wheelchair accessible weight scale, but at the date of our next appointment, we may decide that we don't want to be weighed. Maybe we're afraid of the number that we're going to see, but not everybody is obligated to get weighed, but if there's the option, it has to be there for us. But we have the right to refuse everything, even though it may be clinically appropriate to transfer onto an examination table for an examination. We just may feel that we want to be examined while we remain in our wheelchair. And that's fine. Again, it's your rights and you have to exercise. In our August webinar, we'll discuss patient advocacy strategies to assist you in exercising these rights. In addition, we have a right to be accompanied by service animals in healthcare settings. It's your right to be accompanied by a service animal. And a service animal under the ADA regulations is a dog of any breed, of any size. And a service animal can accompany you into any area of a hospital or medical clinic that's open to the public. In general, you may have your service animal with you during certain examinations and treatments, unless for infectious control purposes. The hospital may prohibit you from having your service animal with you. Also, a provider may not ask you or may ask you to remove your service animal if it's out of control or not housebroken. You're not required to have a license or any documents proving that your dog is in fact a service animal, and the dog is not required to wear a vest or harness stating it's a service animal. Providers are restricted in what they can ask you about your service animal or your need for one. Their questions are limited to asking, 1, is the animal required because of a disability? And 2, what work or task the animal has been trained to perform. They should not ask those questions if it's readily apparent that you need a service animal. Now, under the ADA regulations, you also have the right to be accompanied by a miniature horse, which I think is one of the coolest things ever. Now, the miniature horse is not defined in the ADA regulations as a service animal, but it's recognized in the regulations as being an animal that can accompany you. Similar restrictions apply to that of a service animal, although a health provider can impose reasonable restrictions on the type, size, or weight of the miniature horse, or impose restrictions for safety issues. So that concludes our discussion of federal non-discrimination mandates. And it's important to know what your rights are and what the obligations are under those laws of healthcare providers, because that will make us more effective in our advocacy. There's one state law that I want to talk about, and that is the Safe Patient Handling laws. In my opinion, this needs to be expanded to every state, and it's materially important to us as persons with paralysis and mobility disabilities. I wish I could tell you that the states that have enacted this law did so specifically with us, persons with paralysis and mobility disabilities in mind, but that's simply not the case. These laws came about as a result of the increasing frequency and number of injuries sustained by nurses, nurse assistants, and patient care technicians in the moving and repositioning of patients. We are just the unintended beneficiaries of this law. Now, what you see on the screen is not an example of safe patient lifting. 11 states in total, Ohio, Texas, Washington, Rhode Island, Maryland, New Jersey, Minnesota, Illinois, New York, Missouri, and California have adopted safe patient handling legislation. In general, these laws require healthcare facilities to establish comprehensive safe patient handling programs. These programs include the development of policies and procedures for handling patients, the creation of guidelines for appropriate training, and the acquisition of necessary equipment designed to help healthcare professionals safely lift and move patients. Generally, they only apply to hospitals and nursing homes. The safe patient handling law I'm most familiar with is the one in my home state of Illinois. Here, hospitals and nursing homes must have a dedicated safe patient handling team that is trained on how to safely transfer patients. They're required to have on hand a variety of lift and transfer equipment. They're required to know how to use that equipment and be trained on to safely manually lift us. They must inform the patient of the variety of lift and transfer equipment available to them, including manual lifting. They're also required to document in patients' records what their preferences are by way of being lifted or transferred. In Illinois, we adopted this law after the strategic joint advocacy efforts of the disability community and of the nurses union. This needs to be replicated in every state. More than 2/3 of all Medicaid beneficiaries nationally receive most or all of their care from managed care organizations, MCOs, that contract with state Medicaid programs to deliver comprehensive Medicaid services. Not all state Medicaid programs contract with MCOs, but a large and growing majority do. There are over 270 MCOs operating in the country. A fourth of those MCOs are subsidiaries of 3 national companies, Anthem, Centene, and United Health Group. Now these MCOs have the same obligations as the Medicaid state agencies to provide accessible health care services to enrollees of their plans. It's important to understand that states design and administer their own Medicaid programs within federal rules. States determine how they will deliver and pay for Medicaid for the care of Medicaid beneficiaries. Managed care grew in response to the spiraling cost of health care since the 1980s. To manage health care costs, states contract with managed care organizations and pay them a fixed amount per member for their plans to provide the Medicaid services. As of July 2019, 40 states, including D.C. and Puerto Rico, contract with comprehensive risk-based managed care plans to provide care to at least some of their Medicaid beneficiaries. MCOs are subject to the same federal non-discrimination mandates under Section 504, Title III of the ADA, and just for about another month, Section 1557 of the Affordable Care Act. And here are their legal obligations. Managed care organizations assume responsibility to provide an accessible network of healthcare providers and ensuring they are in fact accessible to meet the needs of their enrollees who are people with disabilities. And as it pertains to us, to ensure they have an adequate number of doctors, hospitals, dentists, eye care providers, behavioral health providers, and others whose facilities are physically accessible and have the appropriate training and equipment to properly treat us. But we know that that's not happening. For example, the overwhelming number of provider directories are meaningless as it relates to describing if a doctor's office or medical facility meets our needs. They typically have the universal symbol, wheelchair symbol, in the description of their facilities that leaves us guessing as to whether they're truly accessible, if they have transfer equipment or staff knowledgeable on the proper care of us, or if they're trained to safely transfer us if we desire. And apart from asking their providers if they are in fact accessible, MCOs do very little, if anything at all, to verify that. Just look at these headlines. In Dallas, again in Iowa, and in California. In California, the Kaiser Health News last January exposed systemic problems with its Medicaid program known as Medi-Cal, and one of its NCOs, which was paid to coordinate care for 400,000 patients, it improperly denied or delayed care for at least 1,400 of them. With great frequency, managed care organizations are denying us medically necessary, durable medical equipment like our wheelchairs. They have approval processes that are not transparent and are not conducted by persons with mobility or any other disabilities. Instead, managed care organizations have people reviewing our requests that may have no idea of what our needs are, no idea what the devastating consequences are if those needs are not met and we don't get our medical equipment that are deemed medically necessary. In closing, the struggle for equal opportunity and full inclusion has in large part been a struggle to change hearts, to change how people view disability and how they feel about persons with disabilities. And as it pertains to healthcare professions, we've failed. As we approach the 30th anniversary of the Americans with Disabilities Act next week, let's reflect on the fact that the landmark civil rights legislation came about as the disability community banding together to make that happen. It wasn't the work of one, it wasn't the work of two, it wasn't the work of many, it was the work of all of us. Until we succeed in changing hearts within the healthcare profession, let us be more deliberate individually and more strategic collectively in exercising our legal rights and enforcing our civil rights within the laws that exist. It may be true that law cannot change the heart, but it can restrain the heartless, the words of Dr. Martin Luther King, Jr. And with that, let's open it up to your questions. Kim, what do we have?
Sure. We have a few questions. I first want to say thank you so much for that really thorough and in-depth and very sobering presentation, especially as we look to the anniversary next week. And before we get to questions, we have some in the queue here, which I'm really grateful to see. We have a couple questions, and I think one of them is similar to mine. And I don't know if you have a direct answer to this, but individuals with disabilities and anyone navigating the healthcare system often has to fight individual battles on many fronts. And regarding the legal side and the healthcare side, are there organizations that help people navigate this? I know that our community is very well informed about their rights, and I'm so glad we reviewed this, but I'm just curious to know if there are resources out there, either at the state or federal level, for people to trying to navigate some of their issues or helping them report providers or navigating their health insurance companies.
Yes, so Kim, thank you for the question. And throughout the country, there's a network of 400 Centers for Independent Living. And Centers for Independent Living, what their charge is to advocate not only for the rights of people with disabilities, but to help people with disabilities live the most independent life that they can. Part of what many centers for independent living do is help individuals with those problems and help advocate for them when needed. Not every center for independent living does, but many do. The managed care organizations in states that have migrated to Medicaid managed care, they have individuals as part of their managed care plan that are supposed to be able to assist people navigate within their managed care network and help address issues when they arise, including at times advocating for patients when needed. Otherwise, it's left to the individual, it's left to the family member who are there to support them. There may be other organizations designed simply to do that, but I haven't run across any other than Centers for Independent Living and what's built into the MCO plans.
Thank you, and I would like to add, the Christopher and Dana Reeve Foundation has operated the Paralysis Resource Center since 2002, and if you go to christopherreeve.org and you have questions about how to be connected to your independent living center, we're happy to do that. We can't provide legal advice, but we certainly can connect you to state-based resources to help you navigate some of these very complicated issues. So again, that's christopherreeve.org if you'd like to visit that. So thank you for that answer, Andrés. Our first question.
Hey Kim, Kim, I'm sorry, something else came to mind. The Protection and Advocacy Organization in every state as well. So PNAs, again, these are legal advocates that are designated by the governor of every state to protect the rights of persons with disabilities. Many of them also can assist in advocating on healthcare issues. So, yeah, supplementing my first answer.
That's a great addition, and we've actually utilized some of their services as a foundation to trying to help individuals. So we can, if it's helpful to contact us directly, we can help navigate people there, but it's easy to find online as well. So thank you. So the first question we have is from Alexandra, and her question is, with respect to transportation, do you have any experience or have had any personal success or know anybody who has had success with a van with a ramp being approved by insurance companies?
So the answer is yes. If the question is whether or not an insurance company would be willing to pay for all or portions of a van, a wheelchair accessible van for somebody who needs it, I have known of cases where that has happened. It's not certain that each health insurer will pay for that. I think there's some advocacy that needs to be done. If the individual has no way to get to healthcare appointments, if they have no way to getting to their job, then that is detrimental and could be detrimental to their health and well-being. And in the long run, it's going to save an insurer money paying out on claims that could have perhaps otherwise been avoided if the insured had the ability through an accessible van that's wheelchair accessible to get to their healthcare appointments and to be engaged, to actively be able to participate in recreational activities and physical fitness activities if they're able to get in a community with the help of a van. So there have been cases. You'd have to look at the terms of the plan. Every health insurance plan and every Medicaid managed care plan, under those terms, they have what they're going to cover and what they're not going to cover. But my sense is that it requires a significant amount of advocacy to get that picked up by an insurance carrier.
Thank you. Our second question is a very big question from Anna, and it is, what do you think is the best way to obtain a widespread change in the healthcare system?
Anna, thank you for that question. There's no single answer. It's, as I mentioned in our closing, it starts with individuals being more determined to exercise their rights and insist on accessible health care. These laws have been in effect for 47 years as it relates to Section 504 of the Rehabilitation Act, 30 years as it relates to the Affordable Care Act. In many instances, in my experience, as a result of my practice, what I find is healthcare providers are simply performing a cost-benefit analysis. And they know what their legal mandates are. Nobody's saying that we're ignorant. We didn't know that the ADA applied to us or that we had that particular requirement. It's that nobody has compelled them to do that. When they enroll in Medicare, there's no survey to see whether or not they're accessible. They simply have to sign an attestation saying that they are. And every year when they submit a cost report, they have to sign also an attestation that they're complying with every federal regulation that applies to them. But nobody is surveying them. The Joint Commission doesn't survey them when they're certified or accredited. The state doesn't survey them for accessibility when they enroll in Medicaid. So one, it begins with the individual to compel providers to do that. And then second, it takes a more concerted and strategic, not lobbying, but advocacy by all of these well-organized organizations, to include the Reeve Foundation, to include the National Council on Disabilities, to include AAPD, to include United Spinal. All these organizations need to act in a strategic, concerted manner to get these issues addressed. These rights exist for a purpose, but if we don't assert them, then they're absolutely meaningless. And these healthcare systems are not on their own. Now, out of their own heart and well-intentioned, they're not going to be doing that. They have to be compelled to get these issues addressed. I don't think we need more laws. We need more regulations in terms of defining what's required with greater specificity. Because as good as the ADA regulations are, what I find is many healthcare providers simply hide behind the ambiguity. Because the ADA regulations do not say that you have to have height adjustable examination tables, providers are saying, well, that's not a requirement. It is if you look at your overall responsibility responsibly, and that is to provide an equal opportunity for us to obtain accessible health care. And that entails making sure that you have accessible equipment. We have to do better. When we don't do better, we enable providers to continue year in and year out to continue what they're doing. So a lot of it's on us.
And I agree wholeheartedly, Andres, with that answer. I'll say that we were so grateful to be connected to you, and I know the next presentation in August will be around, unfortunately, some of the further amplification of these issues around COVID. And so the Reeve Foundation really wants to work with these other organizations and with Andres around raising these issues with members of Congress and finding ways to improve the curricula for healthcare providers and improving that network advocacy, at least the transparency around what's accessible, and hopefully improving or working on with organizations on the regulation side around, Section 1557, like Andres just talked about, and some of the other regulations that have been rolled back. So we really identify this as a huge priority and really want to be more involved in improving it. So over the course of the next few months, we hope to identify ways that you can get involved.
Hey, Kim, let me add that.
Sure.
Kim, let me add that what's sad to me about the gutting of the Affordable Care Act is that when the Affordable Care Act was passed in 2010, it required the Secretary of Health and Human Services to develop model curricula for medical schools, for nursing schools, for professional medical societies to implement curriculum on disability cultural competency. And that was never done. The good news is that there are agencies like Health and Human Services. CMS is now starting and has been trying to work on getting these issues addressed. CDC has been trying to get these issues addressed as well. There's model curricula being developed by a consortium led out of Ohio State University that hopefully, when implemented soon, would be a game changer in terms of teaching young doctors and nurses on how to care for people with disabilities and what it means to be disability cultural competency. So it's not as if there's not things in movement, but they're not happening quick enough in my eyes, and hopefully they can all come together and we can make a significant difference here. If we have the same webinar 10 years from now, we have failed, Kim. And so it's my intent to make sure that we don't have to keep talking about this year in and year out.
I agree. Yes, we will have utterly failed if we're talking about this in 10 years with the 40th anniversary. I have one last question, which I hope maybe you'll have some insight on from one of our participants who is really trying to work on creating some empowerment and goal setting for herself. And she's finding that many of life coaches and maybe some professionals completely lack an understanding of the challenges that she faces and others face who may have a disability or live with physical impairment or mobility challenge. And it often leaves, in her opinion, leaving individuals facing further depression. And she just was wondering if you are, or curious if you know if there's any programs that are competent in helping individuals in this situation.
I would only revert back to the CILs, the Centers for Independent Living. Through their peer mentoring program, they may be able to provide some assistance. But mental health care and helping people with disabilities get that addressed the services are limited, and with the advent of telehealth that became prominent a couple of years, is being heavily utilized now because of the pandemic. That may be another opportunity to get direct services from a mental health professional or a counselor through the telehealth system. But the CILs, I believe in Centers for Independent Living, and they have incredibly talented people, and they're there because they care. They're there because of the great skill that they have, and that could be an outreach. If your local Center for Independent Living doesn't have that, then that's something that you can talk to them about, developing a program to help others with that same kind of concern.
Thank you. And in addition to that, for anyone who's interested, the Reeve Foundation also has a peer and family support program. So there are resources out there that are free, and our peer mentors are trained. So please contact us if you'd like us to connect you also. But the CILs is also a great suggestion as well. So I think that comes to nearly the end of our webinar, unless there are any other questions. I don't see any in the chat box. I sincerely want to thank our fantastic presenter and really are grateful for your time and expertise. And we really look forward to August's presentation.
Kim, thank you. Thanks for having me.
So I hope everyone stays safe and well, and we'll see you or hear you in August. So thank you very, very much.
Be well, everybody. Thank you.
Take care.